Hello and good afternoon, everyone. My name is Hugo Rodriguez. I am a member of the board of directors at the Levy Senior Center Foundation, and we are happy to welcome you to today's Levy Longevity program on matters of the heart, presented by Dr. Royal McKenna. This longevity series is presented in conjunction with Ascension Illinois and the city of Evanston. In these sessions, common issues of concern for adults 55 plus will be discussed so we can learn ways to live well and age gracefully. As always, we appreciate your support of the foundation as we continue to work to connect our community of older adults. I'd like to turn things over to our wonderful moderator and partner in organizing these programs from Ascension, Illinois, Michelle Neisner.
Thank you, Hugo. Thank you, Hugo. My name is Michelle Neisner. I'm an athletic trainer by trade and the sports medicine liaison with Ascension Illinois. I'm going to start off by going over some housekeeping items. First, all attendees are muted for the duration of the presentation. Questions may be submitted using the Q&A feature in the bottom center of your screen. Please do not use the raise hand or chat feature or attempt to unmute. We will not be able to hear or see you. Next, at registration, you are able to pre-submit questions. Similar questions were grouped together and addressed in the presentation. Additional questions will be answered at the end of the presentation during the Q&A portion. Additionally, it is not permitted for this presentation to be recorded by attendees. However, it is being recorded and will be available on the Levy Foundation YouTube channel and website. Lastly, this presentation is intended for information purposes only and is not intended to replace individualized care provided by your respective doctors and/or practitioners. Ascension Illinois and the Levy Foundation are not liable for the misuse of any information presented today. Now, I would like to introduce you to our speaker. Today we have Dr. Royal McKenna with us. Dr. McKenna is a family medicine and sports medicine physician with Ascension Illinois. He treats patients of all ages and activity levels. Dr. McKenna, I now turn it over to you.
Thank you, Michelle. It's great to be here. It's great to be able to get to talk to you today about a topic that's very important, so important that all of us are affected by it. We all have hearts, and so we all are affected by the need to have good health, good, healthy hearts, and what we need to do to be able to maintain good lifestyles. So I don't really have any disclosures or conflict of interests. All the information that I'm sharing is not of my own. I wish I was that smart. But I kind of want to start us from the beginning, because if we're going to talk about heart and our lifestyle, well, we probably should go back in time a little bit and let's kind of think about where has the heart, the idea of the heart come from and how it has evolved over time to kind of where we are in today's society of our, daily treatments, medications, and interventions that we're using. So obviously we've known about hearts for a very long time. The picture here that you can see is a picture by Leonardo da Vinci. Pretty well detailed. I guess he's pretty well known for that. But back in the ancient times, they didn't actually truly know exactly what was going on. A little bit more traditional, conservative ideals back then, smaller groups of people. So when someone was to pass away, it wasn't as common to go ahead and look inside the body to see what was going on. But as kind of time has progressed, we saw different Greek and other philosophers and physicians that started to kind of look at the way that the body was working. And so the ancient Greeks have definitely been considered to be kind of at the primary seat of kind of the scientific understanding of heart, medicine, philosophy, those types of things. So Aristotle definitely is considered for the heart to be the organ responsible for creating blood. Plato thought the heart was as good just for circulating the blood. Like he kind of got that idea. Hippocrates noticed that blood circulating cyclically through the body, through the heart and the lungs. And it was a little bit later that Eratosthenes, about 300 BC, he noted that the heart was truly a pump that caused the blood vessels to dilate. And then he noticed arteries and veins. And unfortunately, at the time, he did not kind of grasp that the fluid was going through this. He thought that this was air, but he also was able to discover that the heart was a pump through the use of the heart valves. So these were kind of the things that were slowly kind of helping with medicine slowly progress until this Greek physician, Galen, came around. He was an interesting guy. He had a lot of interesting ideas. One of the interesting things about him is, well, he noted that the heart was definitely the hottest organ, so therefore it has to provide all of the heat to the body. So there were a lot of things that he had idolized about the heart, but he didn't actually have a true understanding of everything that was going on. He believed that as the heart was filling, that was when all of the blood was getting pumped essentially to the body, and he believed kind of the arteries were spasming in the periphery to kind of bring the blood. And then he had this idea that the heart, as the different chambers of the heart, he thought that the blood was able to kind of perfuse through the wall there, thereby kind of getting the rich oxygen and then giving it to the rest of the body. It's kind of an interesting thought now because it's completely wrong, but this was kind of the idea that they had, and it was set for about 1,400 years until another gentleman started to kind of look at health, at the heart and through animal studies. So this gentleman, William Harvey, so he was a court physician to a couple different kings, but he was dissecting dead animals and humans, and after examining those hearts, he did realize that valves were allowing the heart only to move in one direction. That is how they could see that the blood was getting pocketed and then ejected or circulated through the body. So that he was just able to kind of take a look at kind of the heart wall, and he's just like, I don't see any holes here. So he began to realize that the heart and not the lungs may be responsible for the blood moving around the body. And so in about 1625, he published this De Motu Cordis, and this was kind of like the beginning idea of systemic circulation. This kind of completely overhauled the Galenic kind of ideals of how the lungs was pumping the blood around. This guy was a true scientist, a little bit different times, but he wanted to know how much blood is in the heart. So, well, he ripped one open and he was able to find out. So about 2 ounces. So he definitely made a study of the living of heart rate, circulations. You can see some of these drawings from the book from 1624 are very detailed. I'm sure nurses would love some of those veins today. I'm sure many people in this thing would like those veins so they're not getting poked all the time. So this was kind of the gentleman that began the kind of idea of the modern day thoughts behind the heart, the modern pump, how it was circulating the body. And kind of he gave us the idea, let's look at the actual, what the heart looks like. So he obviously came up with what we all see, right? No, of course not. It's a very iconic symbol, very recognizable throughout the world, but of course it looks nothing like the heart. So I kind of want to take a quick moment to kind of review some of the anatomy and physiology of the heart. We're going to kind of try to keep it at a basic level, but it's kind of important because if we're able to understand basic anatomy terms, this can kind of help describe the location of whatever we're talking about, and it typically describes most of the diseases that you've heard about. And so that's why I kind of want to take a quick moment to kind of review some of these things, and then we can kind of go from there. All right. So where is our heart? You know, we live in the United States. It's pretty common for us to I'm a sports medicine doctor, so I go to lots of sporting events. So we say the Pledge of Allegiance, or the national anthem, excuse me, all the time. And I look up, and for the most part, people know that we're putting our hand over our left side of our chest. Every so often, I see a few people. So our heart, located right there on that left side of our chest, in between that third and our fifth rib. The heart is about, for a male, is about 300 grams and about 275 for a female. I guess a good way to kind of really take a good idea of how big your heart is it's about the size of your fist. So that's kind of an idea of how big your heart typically is and should be. So I wanted to take a just quick look, have this x-ray view. Many people here, when they're gonna go get any type of emergency medical services, they possibly are gonna get an x-ray. So this can kind of show you some of the basic anatomy that we can see, even you know, with a chest x-ray. So we are able to see the heart. We're able to see the way that the heart, where how large it is, where we can kind of see different aspects of the heart, if it's enlarged, those types of things. So kind of just trying to go review a little bit of our basic anatomy. What are the basic parts of the heart? So the heart is divided into 4 chambers, and in a healthy heart, blood flows one way through the heart. It flows through the heart with the valves, and these prevent backflow. The heart is kind of enclosed in a nice protective sac that is called the pericardium, and that has a little bit of fluid, and that is in there to kind of keep the walls greased. And then inside the heart, we have different layers of muscle. The heart is actually layered of 3 different types. We have the endocardium, the myocardium, and the epicardium. And those are just kind of where they're localized into the kind of wall of the heart. So the endometrium would be on the inside. The epithelium is going to be on the outside. When we're talking about the parts of the heart, a lot of times that we see people, the heart gets divided into the left and the right side of the heart. So a lot of figurations, and a lot of what I'll have today is you'll see that colors of the blue and the red. So these are signifying different chambers of the heart and the different locations that they are pumping the blood, and why it's important. So when we talk about the chambers of the heart, we're essentially talking of 2 different chambers: the atrium, which is up at the top of the heart, and that has a left and a right, and then the bottom part, the lower, the ventricles, and those also are divided into left and right. The blood comes flowing in initially to the atrium from wherever it's coming. The valve will open, the blood will get pumped into the ventricle, and then from there, the ventricle is where the blood is going to either get pumped to the lungs or to the entire body. Like I was saying, the right atrium and the right ventricle, many times this will be considered the right side of the heart. And we consider this is where the blood is returning to the heart. It has been out to the body. It has removed all of its oxygen. And now it is coming back to get to the lungs to get full of rich oxygen, so that it then can get pushed back into the other side of the heart, which was now the left side, to then get pumped to the entire body, giving us nice, rich oxygen for the entire body. The whole purpose of why you're breathing every few seconds. All right. So let's kind of talk about how in between those 2 chambers, we do have little valves that are going to allow a time frame for the blood to either go in to fill up, or for the time when it is time to get ejected and the heart is contracting at that moment and pumping the blood out. So again, we can break it down into the left and the right sides of the heart so that we can kind of get an idea of remembering where the blood has come from and where it is about to go. So the right side, again, the blue that we see coming back, that is going to get pumped into the atrium. And as that goes from the right down into the right ventricle, that will pass through the tricuspid valve. So many times we hear about a tricuspid valve issue. So on the left side, after the blood has now been pumped into the lungs and it is now pooling back and returning to the heart, nice full of oxygen, it has gone through now the left atrium, and now it is going to pass through another valve, and we call that the mitral valve. So we also hear other diseases when it comes to the mitral valve. So it's nice to know where these are. When the blood is back on the right side and it is going to be pumped up into the lungs, it also will pass through another valve, and that is the pulmonary valve. So our right side of our heart has the tricuspid valve and the pulmonary valve. And then on the left side of our heart, we have the mitral valve. And when that is pumped, it also goes through the atrial valve, the aortic valve. So those are kind of our main valves of the heart that kind of break up the different chambers and that allow the blood to either pool up to be able to get a good amount of blood with the next contraction, or it is essentially preventing any blood that is ready to get to the body to not pool back up into the area that we've already just filled from. We don't want that to be going back. That is where you hear a regurgitation. So we can kind of talk about some of these diseases that come on later, but it's good to know these initial anatomical locations. So again, just this is a quick kind of recap on the pulmonary valve that's on the right side of the heart that is going to be pumping the blood into the lungs, los pulmones, our lungs. And the different valves, they can be either 3 valves or 2 valves. And so that they can kind of differentiate the valves that way. Some people do have genetic, inherited abnormalities, and this can make their valves not function like they should. And so these are some of the areas where people have later on, they'll have issues with their heart. Okay, so we had kind of talked a little bit about the heart wall. Like I had said, the inner side is the endocardium. You know, the blood is flowing through all of that section. You can kind of see the middle myocardium. You know, that is full. You kind of see the intertwining fibers that you see there, those swirling pattern of get the blood where we want to go. We don't want blood to pool in the heart. That's where if you were to nick yourself, you would start to clot immediately. Well, if blood was to pool in the heart, the same thing. It could also form a clot. And so these are what issues can happen that we're trying to prevent. So again, that myocardium, that swirling pattern, really helpful to kind of keep that striated muscle strong, so we're able to keep a good pump to the heart, and it's able to kind of keep a strong contraction. And remember, your heart is beating every second since you have been born, or even a little bit faster, right? So it makes sense to have very durable, long-lasting tissue, and our heart is very durable. The tissue can sustain quite a good amount of damage and not receive a lot of oxygen before it starts to have issues. Unlike the outer laying of the entire heart is the pericardium. This can kind of come up later on. This is a tough outer surface. It's a very fibrous material. It's lined, this pericardium has kind of a double membrane. And like I had said earlier, this kind of produces a lubrication fluid to kind of help the heart is always beating constantly. So you want it to be nice and soft and be able to make those nice contractions. If anything was to happen, if any fluid was to collect around this, it can get locked in these little membranes, and that can be an issue with a pericarditis and things like that. So the pericardium does come into great importance. Another part of our heart that is very important that we're going to just briefly kind of touch on. This picture is very complex. Look how rich the heart is with arteries. It wants to have blood. It too is a muscle, and it's working all the time when you're sleeping, when you're, during your day. So it needs to constantly have a good, rich blood supply. Now, our heart typically has two main feeders of blood. The left main coronary artery. So these are our coronary arteries. So we have our left and our right. And as you can kind of see, they do branch off, and there are several other branches that are important in the heart. And this is where cardiologists are very important, where they can identify exactly where is a particular blockage in a certain location of an artery, where maybe no blood is passing by, like something has blocked the blood, a thrombus, some sort of impediment of the blood. And so now the downfall, the no blood is getting to the downfall of the muscle, later on in the muscle. So these are where important interventions for a cardiologist comes in with the vasculature. And that's where you hear of people going to cardiac cath labs and those types of things. These are the doctors working with a lot of the vasculature of the heart. Again, like heart tissue, like all cells, it needs to be supplied with, oxygen, nutrients, and it has to have a way of removing these metabolic wastes. So good, this is achieved through coronary circulation, and that's through our arteries, veins, and even our lymphatic vessels. And so, blood flow through the coronary vessels peaks, and it troughs relating to kind of the way that when the muscle is contracting, it's pretty tense in there. It's not easy to get blood through there. So, or when it's nice and relaxed, well, that blood that's trying to get through the arteries, well, that's a little bit easier. And so when the heart is beating, it can influence how much blood is getting into the arteries. Okay. So we talked a little bit about kind of basic anatomy. So now let's kind of go over a little bit of how the heart functions. And we've kind of talked about, where the blood is flowing. And we want to talk about how the heart now wants to beat in a very continuous, in a unified pattern. And it does this because we want to pump blood in a very particular way. If we do not do a very elaborate unified contraction, the blood flow to be ejected out of the heart or to where it needs to go does not occur. And so this is kind of an important thing, is that is the pure purpose of our heart, right, is to function as a pump for our circulatory system and that continuous flow of blood through the body. And this is, this circulation consists of your systemic. That's the entire body circulation from the body, from the lungs, your pulmonary circulation, and away from the lungs. After it's been, filled up with good, rich blood, it's got to get to the rest of the body, especially the brain. So it takes a lot of coordinated effort that we don't ever think about with our heart when it comes to the electricity, how the heart needs to pump, the valves need to open correctly. It's a very incredible engineering marvel. So again, kind of just basic stuff. The blue there on the right side of the heart is bringing back our deoxygenated blood in our veins. So at this point, the blood has been pulled into our kind of larger veins, our superior and inferior vena cava. You can see those at the top and bottom there as they're coming in to come into that right side of the atrium, where they're going to want to get into the right ventricle through the tricuspid valve and then pumped up into our lungs to get that return of rich blood. And once it's gone into the lungs, it's gotten that rich blood. Well, we don't want to waste any time. Let's get that blood back into the left aorta, past our mitral valve into our left ventricle again, now ready for our big pump through our aorta. The aorta is a large artery and it branches into many arteries. You can kind of see in the picture here, it even has, you can kind of see the different branches as it comes up to the head, neck, arches down, and then goes down into the rest of the body. So it goes the arteries down to arterioles and then ultimately capillaries. And the capillaries, the itty bitty, this is where the nutrients in the blood are kind of exchanged. The metabolism, the body still kind of exchanges all of those things. Carbon dioxide and the waste products are kind of exchanged down there in the capillaries. So then now once the capillary blood now has been kind of used, oxygen's been kind of pulled out when whoever needed it and has used it. And now we're back into our little venules, into our veins, and eventually we come back into our return of our circular system there into the right side of our heart. So the period of time when the ventricles is contracting and forcing that blood either into the lungs or to the body, because it's happening at the same time, they be in unison. This is a term that we use a lot in medicine. And so that you will hear this, and this is known as systole. Heart is contracting and pumping, systole. When the heart is no longer contracted and it is now time to relax for a quick second and start to refill with blood, this is known as diastole. And so how do I use these weird terms, Dr. McKenna? I've heard these sometimes in the office. How do I use this? So a healthy heart is providing good blood pressure. And so a healthy heart will give us a good systolic and a good diastolic blood pressure. And so this is where we get these numbers. We've measured everybody out there for, 100 years almost, measuring their blood pressure. And we've realized that the average human being typically has a blood pressure of, when the heart beats, of 120. And when the heart is resting and filling, it drops down to 80 millimeters of mercury. So those are our pressures of when the heart beats and relaxes. Now, if our heart was to be beating really hard, if for some reason that pressure starts to increase, that's where we start to talk about high blood pressure or hypertension. So how do we know what is hypertension? And when do we do anything about it? So again, we said normal was 120/80 or below. And then once we go over that, that's where we start to getting into our elevation. So we say 140/90, you have a full hypertensive episode. And these are something that we want to start to monitor, because we know that it might not be in the very acute moment of having high blood pressure that affects you, but it's over the years of long periods of time of having such high pressures all the time. Well, that can lead to the organ failure and causes of issues with our heart and not having a healthy heart. So by screening for this is kind of an easy way to kind of measure how people's hearts are doing. If you kind of remember, in the 1950s, it was pretty common for a lot of people to have heart attacks in their 50s and die. We didn't like that. We wanted to figure out what was going on. Why were all these people just having a great time and passing away? That's no fun. Nobody wants to do that. So we started noticing that high blood pressure, that could be a cause, and things like that. So these are some of the guidelines that started coming out to be like, hey, if we want to prevent a heart attack, stroke, and other heart disease, maybe if we keep our levels below, we can improve our outcomes or our lives. And it's true, we have definitely demonstrated that our life has definitely prolonged. So a normal heart rhythm, like I had said, our heart has been beating since we were little babies, even in the womb, right? What is a normal heart rhythm? So the electrical signal has to start up at somewhere in the heart. And so we know that this starts up in an area that we have named the sinoatrial node, or we call it the SA node for short. So this is kind of the kickstart of the shock. And in this little picture that you can see here, it's the kind of the very guy on the left side of the screen at the very top. And if your clip works with mine, it's about to start right now. So that would be the SA node. It begins to go down, it travels through the heart, and now it has reached to another area, the AV node, atrial ventricle node. This is another important area of the heart because it has received all of the electricity from the top, and it wants to coordinate it and do this correctly, so it will send it down to the ventricles so we can have a good coordinated contraction. So the signal gets stuck there. It can't go anywhere else. It actually gets stuck there. It's called a septum there. The signal gets stuck, hits the AV node, and then it is able to disperse down through that septum, the very middle of the heart. In the very middle, the left side over here, this being the right, you can see the signal goes down equally, uniformly. It gets to the base, and then both sides will then receive the electrical, and then we get our contraction. So the septum is part of cardiac skeletal tissue that's within the heart. And like I said, that electrical signal doesn't pass that AV, the atrioventricular node. All of this is important because we want good, regular rhythms. Our heart is controlled through cells that are strong in contraction, and that they are able to constantly always be able to have a contraction a little bit later. So 99% of the cells that make up of the heart, of the atria and the ventricles, those are muscle cells. The other 1% of the cells are going to be those cells that kind of control the electrical signal that gets sent down that we were just looking at. And those kind of control the contraction of the heart. So the majority of the heart is the muscle, it beats, but it needs to receive signal, and some of the other cells transmit that signal. The signal is transmitted through an electrical signal, and this is something that we have called an action potential. This is something important that comes in later on for our treatments. I just kind of want to briefly talk about it. I won't get into the physiology. It has to do with our electrolytes, sodium, potassium, calcium. There are many different ways that our cells work with these electrolytes. That's why they're important in our diets. That's why we're eating these things, because these affect the electrical activity in the contraction of our hearts. So if we don't have some of these materials to be able to do that, it's tougher to make these action potentials to do the contractions for the heart. We'll kind of go through some of that in kind of the nutrition and those types of things. So again, we want a nice regular rhythm that is in a good contraction beat. So what would be a heart rate that we would be considered normal? So right, we were looking at our blood pressure. What's a normal heart rate? So it depends on your age, and a resting heart rate, can be pretty variable depending on the person, depending on the family history, the lifestyle factors, the smoking issue, possibilities. There are a lot of different factors that kind of influence our heart rate. An athlete is well known to have their heart rate can even go below 60, but we typically say a normal heart rate is between 60 and 100. If we are below the 60, we say that is a Brady or a low heart rate. If it is above 100 heart beats per minute, that is a tachycardia. And so if the heart can kind of have some of those, that can lead to where the heart does not beat correctly or in unison, or what we call an arrhythmia. So this is a little quick chart that you can kind of look between men and women, kind of look at your age and kind of gauge what is a good resting heart rate for me. When we go through exercise, we'll talk about what is other expected heart rates that we would want during exercise, because that's not when we're resting. So where should it be? Again, 60 to 100 normal. Newborns, very different. The tinier we are, the faster the beat. The bigger we get, the slower our heart rate kind of slows down. Okay. So it is pretty well accepted that the average life expectancy is going to continue to increase. And I think many people who are probably listening to that are probably living the benefits of a longer life expectancy. I mean, look, in the Western industrialized countries, we went from 47 in 1900 to 78 in 2007. So the number of individuals 85 years old has increased 232% in between 1960 and 1990, and it's going to only get larger. That 20% of the population will be older than 65 by 2030, so right around the corner. So it's important to know the anatomical and physiological changes as we are naturally getting older. I haven't met anybody who's getting younger yet. Everybody's getting a little bit older. So if we can kind of recognize what is truly normal physiological aging and what would be maybe pathological differences where we need to maybe do something that's not right. So numerous athletes are able to maintain a high level of participation of sport and performance into the middle age and even well beyond. Many recommendations coming out of the American College of Sports Medicine and the American Heart Association encourage older adults to maintain a physically active lifestyle with an emphasis on a moderate intensity aerobic and muscle strengthening activities, as well as activities that promote increased flexibility and balance for older adults, especially who are at risk for falls. As we get older, the risk for falls becomes greater. So the growth in the number of athletes has definitely been shown at the National Senior Games marathons. I personally have been covering the Chicago Marathon for the past 5 years, and I definitely see several men and women who are over the age of what I perceive to be 50. And I'm probably wrong, because usually those who are active in doing those types of marathons and triathlons and those types of things, you just look younger. It's a part of a good benefit of having that good rich blood flow to the entire body. The body has the ability to clean up waste, repair itself, and you're able to stay and look healthier. That's the no one wants to accept that the true pill to beauty and longevity is diet and exercise. It's the easy pill, right? So we do expect a lot more people to be coming out for more marathons, triathlons as we get older. And this is what we want. We want to promote healthy activities. Older adults that I guess healthcare providers, we like to counsel older adults regarding the health benefits that coincide with active lifestyle. People sometimes don't think that doing or making the extra effort to try to do some of these lifestyle changes and exercise things is really going to help them. I'm 80 years old. I think one of the questions I received was someone, I'm 80, 83 years old. Why start exercise now? So I kind of want to go over some of these reasons. As we get older, we notice the body is starting to kind of change. At the cellular level, we definitely see that the cell's ability to divide and repair itself just doesn't happen. The exchange of nutrition, the cellular waste, and then oxygen when it gets into those capillaries we talked about just doesn't go as well. You start accumulating a little bit more fats, lipids, and pigments. So we see this lipofuscin, which is kind of like, I've been named an aging pigment. So our red blood cells, after 90 to 120 days, they break down. And this pigment just likes to somehow get stored, particularly in our smooth muscles and myocardium. So these are just things that we observe as we get older. These are natural physiological changes. We notice our cardiac output will decrease. And this is due to just max heart rate, how hard our heart is beating, the stroke volume, which is our cardiac output, and our stroke volume together. it will just slowly start to decline. And so these are normal physiological changes of the heart that we do anticipate. But we see regular cardiovascular exercise and endurance training has been shown to increase kind of your VO2 max, that your optimal oxygen consumption. You breathe it in, does your body optimally use all of that oxygen? And we see when people do exercise, we can demonstrate that it truly helps people even 70 years and above. Other things that happen with the heart as we get older, we definitely start to deposit fatty kind of tissue into that inside that, remember the big rich striated myocardium. And so that interrupts where those muscles typically would be nice and be able to give that good contraction. Well, now that little fat cell is kind of impeding that. And so the contraction doesn't happen as well. If those are where the electrical cells were going down, that could impede that. And then that can kind of lead to where the heart signal isn't getting dispersed the way we would like, evenly like we saw. And then that way we can see the heart irregularly beat, or the arrhythmias. Other natural changes with age is the valves of the hearts. They've been pumping and going our whole lives. Well, they will start to thicken and they won't be able to be as sturdy or as they typically were, and they will lose compliance, or so they will kind of start to kind of fail a little bit. And so when that blood was there, it would pool and get pumped out. Well, now it's able to kind of trickle down a little bit. And we see that in regurgitation. So you can see that in tricuspid regurgitation, mitral regurg, aortic regurg. So that's why we talked about all those. We can see how as we get older, you know, the physiology changes. Because the valves kind of thicken, our vascular physiology also starts to change. It doesn't become as nice and resilient. We kind of get built up, kind of got the, kind of chop off the rocks, you know. We build up resistance in our vasculature. And so the blood, instead of being in a nice smooth pipe and going nice and smooth, well, now it hits a hard pipe. And so the pressure is kind of constantly elevated. Our body does several things. It has receptors that will sense our blood pressure from when we stand up to other things. And if we don't respond to that, that can be detrimental. But sometimes our body can go chaotic, and these things can go haywire or not work. And so these can kind of cause a healthy heart to not function normally. So with the pipes are higher, that's typically with the vascular compliance, it's not as much. We see that with higher blood pressure. And we also see that with orthostatic hypotension. So hypo, low blood pressure, and orthostatic is kind of when you stand up. Pretty common for a lot of people. When they stand up, you're now fighting gravity that you typically hadn't been fighting. You have a receptor that senses that, and your body typically wants to tighten the blood vessels so that the blood pressure is able to fight the gravity and get up there. If this doesn't respond, or doesn't sense it, or it's not doing it correctly, the vessel does not tighten, and therefore the blood, when you stand up, it follows gravity and it falls down to your feet. Thereby you feel dizzy, you could pass out, those types of things. That's kind of scary. So those are types of things that we look at. These are normal ages, things with aging of the heart. But if we can figure out that this is what's wrong, these are where the interventions can come in, and why the cardiologists choose what they do. Quick kind of review of other things as we get older that do affect the heart in other systems. Our lungs, the vasculature just starts to become reduced. The number of alveoli where the air is coming in when we take our big deep breath, those start to decrease. And so you just don't have as many of them there to be able to share the oxygen. And so when you start exercising, you're trying to use that, and you're breathing faster because you're trying to get faster exchange. You're needing that oxygen while you're exerting yourself. And so if there aren't as many, this can lead to a decreased exercise tolerance and people to feel tired during exercise. It can weaken our respiratory muscles. We can have damage to the lungs and those types of things with the cartilage from smoking history, other things, and that makes our lung not as compliant to be able to get the oxygen out. These were all physiological changes that can affect our heart, because then we're not able to get the blood oxygenated and returned back to the heart in an effective manner. Our heart is pumping blood at all times, and the guy who is really sensing a big amount of it is our kidneys. And so as we get older, we start to lose also some of the inside portions of our kidneys, the glomeruli. And this also comes along with kind of the rigidity that's coming along with the rest of the vasculature and other places. This is due to atherosclerosis. What is that? That's our cholesterol. When we have cholesterol in our arteries and veins, our arteries, right? And so this is where we can get a buildup of plaque, cholesterol, and there's just not as much room to go by with the blood that's trying to get kind of sucked up by the kidneys. So these are all normal things that happen when we get older. Start making a little bit less urine, other things, but this can affect a senior athlete's ability to stay adequately hydrated, especially if you're exercising a lot. So again, I'll repeat that. Your kidneys don't have the ability to concentrate your urine as much. And a lot of times that's why we go to the bathroom a little bit more. So when we go out and we're exercising, we can become dehydrated a lot faster because our body is not concentrating the urine or trying to keep our water in our body. Instead, it keeps making urine and it doesn't help us. And there we can have lower blood pressure, and that can be an effect on our exercise and the way that we feel. Lastly, as we get older, we also know that our hormones obviously start to decline in various functions, where we can have several diseases. Type 2 diabetes is probably the most commonly known. But one of the ones that I like to always bring up is that middle one, that adrenal function is reduced. We reduce our testosterone. This kind of affects our ability to regulate the fluid in our electrolyte balance. So again, this comes down to a lot of, as we get older, we have to really be very conscientious on how much water we are drinking, because when we're young, many people, we just don't drink very much water. We're always told to, but we don't. But as we get older, the effects of not doing it actually become much more pronounced, and they do affect the internal organs. And again, we stop making special factors in our skeletal muscle as well, like insulin growth factor. And so this will decrease our muscle mass. It's very, very common as we get older, everybody, as we start to lose our muscle mass. And we'll talk about why. Again, other systems, our nerves get a little bit impaired. You probably noticed that with our hearing, memory, balance, our cognition, and our fine motor skills. So again, these are very normal things, but these are effects that can affect our ability to exercise and to stay fit in order to have a healthy heart. A healthy heart also typically leads to a healthy body. Other things with age, we start to lose kind of our vision acuity, adapt to low light situations. So we kind of know that these are all affecting our body. The big one that I see a lot, since as a sports medicine doc, the senile sarcopenia, which is that kind of age-related decrease in skeletal muscle mass. You typically see it around age about 50, maybe 55, and then as the years kind of progress, you'll kind of lose about 1/3 of your muscle mass as you age. When we look at the cellular level, this is just due to kind of the decreased numbers of cells, just don't regenerate as much muscle cells. And if we injure, we just don't have a great response. Our body does not elicit as a reactive of a response. If you're looking at kind of the fibers and the extracellular dysfunction, you can kind of tell that the bands of where the fibers of the muscle using the actin myosin crosslinks, they just are stiffer. So flexibility and balance become a big deal as we get older, And this is just because to this dysfunction of this cross-linking in our muscles. And so as we get older, elderly people are much more susceptible to muscle strains and ligament injuries because there just isn't as much give way as there is when we're younger. One way to combat a little bit of that is making sure we stay hydrated. Other things that we know that happen as we get older is with our bone density. Particular females, we know after menopause, we just, due to the estrogen levels decrease, we just don't have the bone mineral density that we have. Is why the recommendation at the annual screenings with your doctor at 65 is to get a bone density scan. But men also are losing bone mass, just like women, as women, but just not as much, quite a bit less, to be honest. So men aren't as affected by the fractures, stress fractures, and injuries postmenopausal as postmenopausal women are. And it unfortunately kind of gets, it can accelerate a little bit with the bone mass as we get kind of further through menopause. So with all these effects, you know, all these terrible things that are happening as we get older, why should we do any exercise? Is there any evidence behind it? And without a doubt, yes, there is a continually growing body of evidence that does establish that exercise in aging athletes is very recommended. The American College of Sports Medicine is advocating heavily for combined physical activity regimen for all adults, including resistance, endurance, flexibility, and balance training. And so let's go through some of this now. So this was a study published in the American College of Sports Medicine where these were factors that they found that if they were able to provide these things, endurance, resistance, flexibility, or balance for this prescribed amount of time for a certain amount of intensity, that we could show quite a significant improvement in people's exercise level, endurance, and we can decrease risk of mortality and improve heart health. So decreasing diseases like diabetes, cardiovascular diseases, mental diseases, cancers is very effective, and they are definitely lower in people who engage in consistent physical activity. This is just, we know this. Your body gets the good blood perfusion all around. Your body has the ability to find, remove waste better. So the incidence of mortality and amount of functional disability are also lower in active aging populations. So they found for endurance, if you were to do 150 minutes with a 5 to 8 intensity for about 10 to 30 minutes, this would provide a level of protection, decreasing of the mortality and functional disability. Resistance training, 8 to 10 exercises of 8 to 10 repetitions. All of these are kind of at a moderate to moderately high intensity. With that is, they recommend 2 days out of the week. Same with the flexibility, so good sustained stretches, static, not holding in non-ballistic movements. And then balance, so progressively kind of posturing, standing on one foot. We'll kind of go through some of these as we go through. The benefits of exercise in the musculoskeletal division is almost uncomparable. It helps with the bone mineral density. We definitely see that. It helps with that offsetting of the sarcopenia, where we're losing all of that. Resistance training in elderly adults has been shown to increase muscle strength and cross-sectional area, like increased joint range of motion, and they're able to improve kind of like their dynamic balance. Although structural alterations in tendon and ligament tissues are observed with aging, mechanical properties can be improved with regular physical activity. Physical activity has been known to result that you have better tensile strength, you got better ultimate load, the mechanical stiffness of the ligaments. You're able to preserve the size and the properties of your tendons. As we get older, we notice we start to lose some of that. So age-related cartilage volume loss has been demonstrated with exercise. So I kind of want to repeat that. So if you were to do no exercise and just your normal age is going through, we have a little bit of cartilage loss, cartilage volume loss. However, those elderly adults who do participate in these resistance training, range of motion, balance training, they don't lose as much cartilage. And so this is important for osteoarthritis. We don't want arthritis as we get older. These kind of things become sometimes inevitable based off lifestyle choices, work, things like that. But so people are always like, how can I prevent this now? And the best thing is doing musculoskeletal exercise. And so participating in that moderate to high intensity activities that, we want to load the knee. We want to strengthen the knee from extension to flexion. We want to be able to decrease the tension that's getting put on the patella, your kneecap. So if the quad is strong, the ability for the knee to bend is better. And so therefore you are able to have greater strength and proprioception where you're walking. And this leads to decrease in injuries and a better improvement and decrease in osteoarthritis later on in life. Quickly, we all know if you exercise, it's going to help your heart, even just a little bit. Kind of moderate aerobic activity has cardioprotective benefits. We see with the cardiac output, when our heart beats, when we're exercising, this just maintains better. You were able to have that additional cardiovascular benefit of increased vascular compliance. They're nice and soft. We keep our blood pressure low. We don't have as many of those cholesterol plaques. So these are all important things that we see with cardiovascular changes while we're doing exercise. We want these exercise changes. We want to have these benefits because they are greatly needed to help have a healthy heart. So if these are all so great, who should be exercising? Who shouldn't be exercising? Do I need to get tested if I'm going to start an exercise regimen? So these are all great questions. I got a couple of these earlier. So a pre-participation medical evaluation. If we're going to go out in general, exercise, does not provoke any type of cardiovascular events in typically healthy people with normal heart and health cardiovascular systems. Those people with high cholesterol, we know that they have atherosclerosis. We know they might have some sort of reason their heart isn't beating right. They had a heart attack, a myocardial infarction. We know that those types of people, yes, those probably people need to be seen a little bit earlier. But there's, so people with atherosclerosis or decreased cardiac performance are at an increased risk for having an acute myocardial event. So these types of people do need an evaluation. Most people do not. Exercise does not provoke this, but the risk is compounded with people who are about to start a brand new intensive training regimen. You're gonna see Dr. McKenna tell you you need to be working, and right now you're about to start the greatest workout you've ever had. Well, this is where, yes, you can really hurt yourself, and maybe we need to kind of take it easy. So what are some of the recommendations that we have? Again, heart attack is pretty low in healthy people, but the American College of Sports Medicine does warn people that anybody who participates in extremely vigorous, that would be that 9 or 10 on the at a 10 intensity scale, always have a risk of having a heart incident or a myocardial infarction. It doesn't matter your age or if you have known heart disease. So kind of returning, older adults with more than 2 of these risk factors that I'm about to talk about, these are people who do require an evaluation with a physician prior to starting a workout, like a high intensity or a moderate intensity exercise regimen. Again, the American Heart Association highly recommends all people who have 65 years old and 2 risk factors that I'm about to go through, that they do receive some sort of pre-participation exercise testing for any masters athlete. So we'll kind of talk about that. What are these? So these are kind of the risk factors, pretty common: age, family history, hypertension, obesity, cigarette smoking, high blood pressure, high blood sugars, a sedentary lifestyle, are all going to be. So if you have 2 of these criteria, which a lot of people I think listening today are probably going to meet that age criteria, men over 45, women over 55. Well, now you have 1 of your 2 check marks. So now, do you have any of these other things? Did anybody die of a heart attack? Anybody suddenly die of a heart attack before the age of 55? Were you a former smoker? Did you just recently quit within the last 6 months? Do you have high blood pressure? Remember, above 140/90. Doesn't matter of the 2 numbers. Do you have high cholesterol? We're about to go through some of those. Do you have high blood sugar? Is your BMI over 30? Or have you not participated regularly in any type of moderate intensity exercise for like 30 minutes for some portion of the week over the last 3 months? If you haven't done that, which unfortunately sometimes is quite a few of us, I can probably meet some of these of not wanting to go out and get a good exercise regimen all the time. But so these types of things do warrant an evaluation. So what are you going to get at your medical evaluation if you were to come in to get a pre-participation screening? Well, we are going to look at that blood pressure. We are going to ask you if you have a smoking history. We will do a basic cognitive exam. It's good to know what your baseline neurological exam is. And then we typically like to do some basic labs, a fasting lipid panel that will be checking our cholesterol. We like it fasting because it's consistent, and that is the best way that we're able to kind of make medical decisions based off of cholesterol. And we'll go through some of these decisions. We check for sugar and HbA1c, which measures our sugars over the past 3 to 4 months. And then sometimes we'll take a look at the electrolytes, sodium, potassium. Remember, those do affect our heart and our heart beating, our kidney, liver function, make sure those are well. Sometimes we'll perform an EKG, or we say an ECG, an electrocardiogram in the office, but not always. Typically, if you've met those criteria, we need to move to that next thing, the exercise stress test, all right? And then another thing we perform after, with all of the stuff that we collect with the information from the labs, we're able to calculate a formula that will let us know what is the risk that we possibly might have a heart attack or a stroke over the next 10 years. So a few other quick blood tests that maybe physicians might run in your office if they're worried about something in your heart. A BNP, which looks to see if the heart has stretched, some type of heart failure. Troponins, people hear those often when you're having a heart attack. One way I've heard the best way to how to explain what troponin is, it is a good biomarker for the heart when the heart is spasming because it is not receiving the oxygen for whatever reason. There's a block in the clot, something. So I've heard, have you ever gotten punched in the stomach, ooh, and you kind of sit there and you kind of quiver for a while till you get that is what's essentially happening with the heart when it's not getting oxygen. When that happens, our body releases this biomarker called troponin, and we can measure that. So this is a very specific marker to say if there is some sort of heart tissue damage or ischemia where the tissue is not getting oxygen going on. Other tests, blood tests to check out for any anemia. And then there's every type of imaging out there can look at the heart. So once you get your evaluation and those types of things, a treatment based off all the what could be possibly, what is anatomically wrong, what is physiologically impaired going on, and where is it being impaired? How can we treat this? Well, that's where all these different medical treatments come into play, and the cardiologists have a big playbook to be able to use. So quickly, one of the tests that we would run here, big for us, cholesterol. So a lipid panel or a lipid profile. So those things that you see on the left, the cholesterol triglycerides, those are HDL and LDL. These are things that we would collect from our lipid panel. A cholesterol typically likes to be below 200. The way that we're able to get our total cholesterol there up at the top is they look at that HDL and the LDL, where we have our healthy and our lousy cholesterol. HDL, healthy, that's our good cholesterol. This is the cholesterol that goes through our body and it sucks up all the excess cholesterol, kind of a fancy thing. So if we have a number over 60, that will protect your heart. I've seen people as high as 100. Some people can have a good, healthy, high-level HDL. Food, dietary, and exercises are the best ways to have high HDL and limit smoking. Smoking decreases your HDL. So we want high levels of HDL. We want low levels of LDL, that bad cholesterol, right? And if it is over a certain threshold, this is where we start to think about maybe starting medication that can help prevent those atherosclerosis or those clottings that could happen in the arteries of the heart or other vessels and cause blockages. So we have medicine that can kind of help with these types of issues with our cholesterol. And the other thing that we check here are triglycerides. So triglycerides are a very common, I think it's most common, it's your type of fat that you're found in the body that's providing energy for the body. This is very high potent stuff. This is what why your body stores fat, because it is such a good energy storage form, so that when you need it and you need energy, you need to give energy to the brain or any type of the body, your body has a form of energy. So looking at our cholesterol panel, this is what we are able to kind of make a decision if we need to start any medication. And we will go through that in 1 second. Other thing that we talk about is that exercise stress test. So you've met those 2 criteria on our risk factors: age, smoking history, family history, whatever it may be, obesity. Now you've come in, we're here to do a cardiac stress test. Is this a scary thing? Well, no, it's pretty simple. You're essentially just going to be getting on a treadmill. We're going to be checking your vitals. You're going to walk on it. We're going to keep checking. We're going to check your blood pressure. We're going to check your heart rate. And we're going to continually increase the intensity of that treadmill, because we want to start pumping up that heart rate. We want to see if you're able to endure a higher heart rate. Are you able to endure good exercise? So one way we're able to measure this is something called a maximal heart rate. And so the way we know that we're able to calculate a maximal heart rate is a simple formula of 220 minus your age. So let's say you are 80 years old. So we would do 220 minus 80 would be 160. So our theoretical maximum heart rate we would want to get at that age would be 160. So we're trying to get near this with the exercise stress test to kind of provoke if we were having any of those types of symptoms while exercising, if we were to feel short of breath, difficulty breathing, headache, other things. So we look for a targeted heart rate based off of that estimated maximum heart rate. So when we want to do that moderate to intensity exercise, we would say that's a 64 to 76%, 6 to 7 intensity level. Well, we take your age, kind of I've done here with the example 220 minus 50, they have their estimated max heart rate of 170, but they only want to do 64% or of a moderate level of that. So they need to get to at least 109. At a 76%, the max would be 129. So then they are trying to essentially do moderate exercise with the heart rate remaining in that 109 to 129 range. That would be what we would deem appropriate for your age and reaching the appropriate level of intensity that we would want for a moderate intensity physical activity. So for those who might be listening and are afraid that I've had a heart attack, I've got coronary disease, I just want to make sure that it is very well known that exercise with light, vigorous intensity, that's like your moderate, heavy gardening, jogging, cycling, swimming, any of these fitnesses are beneficial to patients with established diagnosis of coronary heart disease. So those include people who have experienced MI, heart attack, lowering mortality. People who do these exercises, we show they do have a decreased death rate. They'll decrease mortality from a heart attack. They have less chest pain, that angina pectoris. And we see that their heart is actually able to functionally improve a little bit. The functional capacity is better. And these are things that we are wanting to see out of exercise. This is why we're doing it. So now we've done that lipid panel. We've received a bunch of results. What is the evidence behind starting medicine to prevent heart attack, stroke for people with cardiovascular disease, and we don't want to if we have high cholesterol? So it was really nice a couple of years ago that they did a very fancy study in the United States Prevention Service Task Force, a mouthful for you there, I usually get it wrong. They came up with a nice formula that would be able to kind of predict what is your risk over about 10 years. And if you meet a certain category of criteria, well, maybe we should have a discussion with your doctor of maybe starting a medicine, which is typically called a statin. So this is a medicine that lowers our cholesterol. So this is kind of the calculator that from all of those labs that we did at your initial medical evaluation, your lipid panel, your sugar panel, we've taken your blood pressure, we've asked for if you smoke. Well, we know what you are now. So we're able to put this into a calculator. And this is able to give us a percentage of over the next 10 years, what is the chance that you're going to have a cardiac or an adverse event? Those are kind of the basic things, and we make a decision based off that. There are a few other risk enhancing factors like family history, premature heart attack. You know you have a family history of high cholesterol. It's in the family, like it's a genetic issue. You deposit storages of glucose differently, triglycerides. All of those would be a little bit different in the way that we calculate some of these. If you've got chronic kidney disease, psoriasis, inflammatory bowel disease, these can kind of change the way this calculation is formed. But for the most part, this is a pretty general form. It gives us a basic number that lets us know, can we just do basic lifestyle adjustments, exercise, diet, or do we need to start maybe thinking about a statin? And then if it's really high, do we need to start maybe a moderate to high dose statin to kind of prevent any of these types of things? If after you come to this calculation with the information you've been given with your initial medical exam with your doctor, and this ASCVD has been calculated, let's say you're still there, that borderline or intermediate risk, and you still don't know if you want to start the statin, another test that is available would be the coronary artery calcium score. And that is a CT scan where they're looking at the calcium, and that can kind of help to give a little bit more determination. So there are options with this. This isn't the final say. But overall, statins are very well tolerated, and they are have been known to dramatically improve outcomes in people later on in life with high cholesterol. Okay, so exercise is essential. 150 minutes per week, 30 minutes a day, 5 times a week. It kind of doesn't really matter. There's several different formulas of way that you get your physical activity that you need that's essential. And we're going to kind of go through a couple of those, but it doesn't really matter. Hiking, jogging, but we do want those 2 days of a week of activities of strengthening, and then also balance. Those are going to be very important. If you have chronic conditions that affect, standing, walking, jogging, things like that, we need to find other activities that would allow you to do it. It is about getting your heart rate. It is about breathing fast. It is about expelling that oxygen, getting that CO2, that is where you're expending oxygen, energy, and you are burning calories. One way of checking your physical activity intensity is kind of doing that calculation, like I had said, your target heart zone of your moderate 75% of what your target heart rate should be. And that can kind of give you an idea of how intense is your physical activity going right now. Do you want to increase it? Do you want to decrease it? I did get a message and I forgot to put it in my thing of wearable technologies, watches and everything. They're the thing. There is some studies coming out with that they can measure a lot of things. I think that it warrants maybe a complete other topic for wearable technologies in the future and what we're going to do with them. But yes, there is possibilities with it, but it is not the only tool that we're going to be able to use. It cannot circumvent any type of medical evaluation. So this is taken from the CDC and their website of different examples of getting a physical activity, whether for that 150 minutes, whether it's 30 minutes, 5 days a week, it doesn't really matter. And then making sure that you supplement it as well with your muscle strengthening activities at least 2 days a week, strengthening all those major core, legs, hips, back, chest, and then balancing, standing on one leg, using a wobble board. And we like to do that I recommend about 3 times a week for all of this for a good overall healthy aging athlete. So for those people who are now like, I'm ready to do my exercise. Dr. McKenna got me, I'm ready to do it. Well, all right, let's do it, but let's chill out. Let's take it nice and slow, right? Brisk walking, I think that's the way to go. Start off that with a total of 50 minutes. Any activity is better than nothing, right? So we're gonna start with this very low intensity activity. If you're really deconditioned, if you have chronic illnesses in the past and you haven't been doing anything, that's okay. That's all right. We want to do some sort of activity. Some activity is better than nothing, right? Get in the pools, get into fitness classes for strengthening and balance and those types of things. They're everywhere through the community. YMCAs, community centers. If you're into it, get a trainer, get a pedometer. So same thing, those wearable technologies that can let you know how many steps did you do today. People always put the 10,000 at the goal. I say start at 6,000 and slowly work up and increase by 10% every 2 weeks. You increase your walking by 10 minutes every day, and then we slowly are able to kind of build that up. There's several different tests to kind of perceive our exertion. So everybody kind of knows if you're doing a low, moderate, or high intensity workout. Quick references, I got a lot of this stuff from the CDC. They have great website recommendations for activities, calculators, things to meet. They have pamphlets that we're kind of reviewing physical activity guidelines. So they have several exercises. They show you how to do them. So please take advantage of these websites. They're free and they're great. They're exactly what I was looking and telling you anyways. When I was looking up, I was very glad I actually saw a lot of stuff from them. So again, as we get older, we just don't have our metabolic rate decreases. So this affects about how much we need to eat, how much we need to exercise. Aging athletes typically lose weight. Combine physical activity. Hold on. If you are typically aging athletes attempting to lose weight, they combine physical activity with a decrease in caloric intake. And this can lead to a negative energy balance, right? Your total, how much you've consumed for the day and how much you've burned, you have more burned. So you're in a negative energy. So a deficiency of 1,000 calories results in muscle breakdown, catabolism. And this is just not good efficiency for your metabolism. We know for a fact, if this is what you're doing, as we get older, you have serious risks of decrease in bone mass and risk of bone fracture. So we don't want those types of things. So we don't typically recommend a negative energy balance, physical activity with decreased calories, right? So we try to kind of keep it at an even balance. The older we get, unfortunately, I know we don't want fat, but unfortunately it does protect us as we get older. So quickly going over some of our diet. So the older we get, the fewer calories we need to maintain the same weight. So it's more emphasis on the quality of the calories that we're doing and not so much the quantity. And then training volume is a very key factor in predicting energy needs and your nutrient requirements. So typically we want to have a carbohydrate intake of about 45–50% of our total calories that we take for the day, typically about 5 to 7 grams per kilogram per day. That's what you need for your carbs. Protein, that intake a little bit less, right? They haven't even truly established a true recommendation for it. So it ranges from like 1.2 to 1.7 kilograms per kilogram per day. This does provide those amino acids that helps provide the necessary amino acids for that muscle synthesis and repair, those 20 essential amino acids. And then recommend daily fat intake should be about 20 to 30% of all your total daily calories. Low-fat diets have not been shown to increase athletic performance, especially as we get older. Fats are helpful, and there are lots of healthy fats, avocados, olive oils. There are healthy fats. We don't have to have greasy fast foods. One of the things that they've noticed for people over 50 are deficiencies in vitamin D, vitamin B6, and calcium. There's really a lot of lack of evidence to say exactly how much they need to have. So that's kind of where this kind of comes as a caveat. The most important way that we're going to supplement and get all of those vitamins, vitamin D, vitamin B6, vitamin B12, is through our food. So I've here kind of listed rich foods in these different categories. If you were to be told by a physician that you are deficient in your vitamin D, vitamin B6, calcium, well, the best way you can supplement it, even better than all the new vitamins that definitely don't do much for you, that they're definitely showing now, it's through the foods and being able to have optimal absorption of that food. So vitamin D, I'm going to quickly graze over this. It's a very controversial topic. It used to be they thought that vitamin D was really important, and they thought that if we supplemented it, a lot of people with chronic diseases would get better, and they just don't. It's not vitamin D, just people who are sick. They just typically everybody has vitamin D loss there. And it has nothing to do with any supplementation. It doesn't truly seem to improve outcomes. However, it's been so established for a long time. I'm not going to go against the grain at the moment, but so these are kind of the recommendations. We do know vitamin D is important for reaction time, balance, and bone strength, so if one falls and things like that as we get older. Calcium, also equally important in bone health. The typical recommendation of how much you should supplement is 1,200 milligrams of calcium per day. There is vitamin supplementation, and then also through food, I think is also very good. Vitamin B6, this is necessary for those storages to have energy in your muscles. And so we need more of this as we get older, and we should typically consume about 1.7 to milligrams of kind of the vitamin B6 through our food every day. And this can kind of help with those energy storages. What is maybe something we need to decrease? We don't always hear about this, but iron is one of those micronutrients that we can typically have a little bit less, especially for women after menopause. You're not having your menstruation and having monthly menstruation, so you're not losing as much of your red blood cells, and the need for iron isn't as great. So we can decrease it a little bit. If you were low on iron, remember vitamin C, in addition to iron, definitely helps you absorb more of the iron. But the thing I want to drive the most is deficiency of most micronutrients is very rare if athletes consume a balanced diet of fresh fruits and vegetables. Fluids. So staying hydrated, you're exercising, you're going to be needing to stay hydrated is paramount because you are going to be losing so much fluid, you need to compensate. You are going to have a diminished thirst response. Remember, your hormones are not making as much. You're not able to concentrate your urine as much. So you are going to have greater losses of fluids than you did when you were young. And so adequate hydration can help keep, heart rate good, not too high, core level down. And you typically, when we get older, we don't recommend going based off thirst. You should kind of regularly schedule it. I've heard the rule of thumb is how much water should you drink per day? It's how much your weight is in kilograms. So if I'm 100 kilograms, I need to have half of that. I need to have half of that in ounces of water. So 100 kilograms, I need to have 50 ounces of fluid. And usually half of that should be some sort of clear water. That's kind of a rule of thumb to be able to keep hydrated. But let's kind of talk about things real quick. We're exercising now. You've seen the doctor. He's given you permission to go. But now some things are starting to happen. You're starting to know you've got some issues going on. Well, what would be some warning signs that, hey, this is going on? You probably should go talk to a doctor or maybe even seek emergent medical attention. So let's talk about the heart attack, the scary one, right? You got pain or discomfort in your chest. A lot of times you feel very lightheaded, you feel nauseous, you want to vomit. You can get jaw pain, neck pain, back pain. Pain will radiate typically up into that left shoulder. That's kind of where when we're a little baby, that's where the fibers there, they stretch out. So we typically feel the heart pain is referred up to that shoulder. You can feel short of breath. Men and women experience heart attacks differently, unfortunately, so we can't always rely on just one set of things. So you kind of have to kind of look at some of these symptoms and kind of gauge, do you have any of those previous risk factors that we talked about that would require you to have any type of exercise testing or any other family history, those types of things. So a lot of the same things that we kind of talked about, extreme fatigue, indigestion, pain in the lower chest, abdomen, also really commonly reported with women who are having issues of a heart attack. A heart attack would be where the heart is no longer getting blood from some reason, and the heart is not beating correctly anymore. It is spasming. Another issue that we might possibly see, chest pain, especially when you're working out. Ooh, as soon as I go upstairs, this starts to kind of really pull on. Ooh, I'm really short of breath. I got up and went from my couch to the refrigerator, and I had to stop to take a breath, take a break. That would be worrisome. I stand up, I'm really dizzy, lightheaded. You have noticed your legs are starting to get swollen. You can even put your finger and push in and see it. You've gained a lot of weight lately. You feel really bloated. You feel tired. You feel really weak. This is the pitting edema. This is where the finger can go all the way in. This is where the collection of fluid is started to collect down there because the heart is not pumping right. The kidneys are not absorbing the blood well. And so the fluid has to go from the blood somewhere. It likes to follow gravity. So here it goes and it pools in our legs. Other issues that something we can see is when our heart is not beating in the right way. You can kind of feel a flutter. People talk about a butterfly sensation. Feel sweaty, palms sweaty, chest pain, lightheaded. All of these things would be things that you definitely need to go get evaluated by a medical professional. So to quickly kind of just, we're going to go through some of these quick diseases. I don't want to go into them in depth. We're going to kind of break them down into kind of categories because the categories are similar. Inside each category is a enormous amount of where they have very specialized what is wrong with the heart. And based on that, they have very particular treatments. We're going to go over kind of maybe the very highlight ones, but for the most part, we're going to just kind of briefly kind of touch over the large topics of cardiac disease. Okay, so one common one is atrial fibrillation. I like this little video because you can see the signal that typically on the left is going down nice and smooth, just the way we like it all the way. It is just sporadically going. Fibrillation is kind of like that spasm, and you can kind of see how that is occurring there up at the top. Remember, the atrium was our top portion of the heart. So that's why it is atrial fibrillation. The top part is spasming. So cardiovascular disease, #1 cause of death worldwide. Most of the disease is not passed off, right? You're not getting it from an infection, or you're giving it to somebody and then you get a heart. It's lifestyle stuff, right? And getting older, right? So heart disease is the major cause of death, 30% globally. So breaking these down, again, enormous categories, but one portion of heart disease is ischemic heart disease, where something is blocking the blood from going through the arteries. This is typically the most common one that we see is coronary artery disease, and that is caused by the cholesterol. That's why we check that lipid panel. So those fatty deposits build up in our arteries, and that can kind of prevent the flow to our heart. So sometimes the interventions go with cholesterol stopping medications, decreasing our cholesterol. Maybe we need an intervention to clean out those cholesterol plaques. Maybe we need to have a stent put in there because it's been blocked, and if we have that open, we have a little bit more blood flow. Another huge category, heart failure. There are many assets of this, is whether the heart is failing because of its pumping, it's failing because it's not filling back up good with blood, is it failing because that the valves aren't working right? Essentially, heart failure, a very broad category, is defined as the condition where the heart is unable to pump enough blood to the demands of the body, right? Patients with heart failure, they typically, the most common thing, they feel short of breath, breathlessness, and they typically see that lower extremity swelling, that ankle swelling, and that pitting edema. Cardiomyopathies, these are a little bit rarer for overall. These are typically these are diseases that are something is structurally wrong with the inside of the heart. The muscles, they're dilated. This can typically be a genetic predisposition. A lot of that is typically what these are. We see a lot of the cardiomyopathies in the sports medicine. Those were for those basketball players or soccer players. They have the sudden cardiac death. So it is something that is mechanically wrong with the musculature. There's too much muscle, there's too less, heart's too big, whatever. That is what's wrong with it. So we call that a cardiomyopathy, and another classification of heart disease. So quickly, I wanted to kind of show that this is a good little presentation of, we have a buildup of cholesterol from our lipids there. You can have a little portion even break off, a thrombus. So if the cholesterol or that atherosclerosis is starting to narrow, stenose any of that artery, the blood flow is going to slowly decrease. But it doesn't always mean that because blood flow has gone down a little bit that you're going to notice it. So a relatively minor one, you might not have anything. So severe narrowing, that's when people are having the really, that's like your typical heart attacks type. People can't breathe, chest pain, those types of things. These plaques can form like this, and then they can break off, and then they can go down further on where it gets a little bit more narrow, also blocking that. Or you can expose kind of like the fatty accumulation to the bloodstream and have that kind of keep breaking off. So when we talk about ischemia, there is reversible and irreversible. And ischemia is essentially talking about death of tissue, and myocardial is tissue of the heart. Like I had said, our tissues are pretty resilient, and certain tissues can maintain a certain amount of time without receiving oxygen better than others. The brain is the worst. It needs about 2 minutes. If it doesn't get oxygen, like if you were to go drowning, you don't have any oxygen, the brain will start to go ischemic and start to die. However, heart cells, that's not 2 minutes. They typically need like 45 minutes to like 3 hours to really start to show damage. So before the true damage of ischemia happens, and that is where the cell dies and nothing can be fixed, it can be reversed. So myocardial ischemia, reversible, can happen if it's within a certain amount of time frame. So that's why time is important. If we get there within a certain amount of time and we're able to get blood flow back to that area, the cell can regain function. But once it's hit a certain point, and everybody is a little bit different and not everybody's exactly the same. I can't just be like 44 minutes and 7 seconds. That's when it's done. Everyone's a little bit different, but that irreversible moment, now the cell is going to die. And if it's in the heart, if it's a lot of these guys, well, now the tissue is there, and now he is not going to do what he typically likes to do, that nice contraction and relaxation now. So this will then start making the heart not beat correctly, and this can be problematic. So what is the difference between reversible and irreversible? Myocardial ischemia is time, and it's when that cell is going to get blood flow back. And that is the only determinant of it. Once it's gone, it's gone. Okay. Last couple classifications real quick to talk about cardiovascular disease. Really common cardioarrhythmias, your atrial fibrillation. So this is while the healthy heart, waves of electrical impulses originate in those sinuses, and they go through the whole thing down to the ventricles. If this is disrupted, the heart will start to not beat in unison, and we call this an arrhythmia. Sometimes it's the heart is beating too slow. That's a bradycardia arrhythmia, or maybe it's beating too fast, a tachycardia arrhythmia. So these are all forms that could be in arrhythmias, but something is causing this electrical impulse to not be sent correctly. Atherosclerosis, there's a lot of things. But so if this is the cause, it's the electrical impulse, that's where certain treatments also go down that pathway, and why we prevent the consequences of someone who might be having this occur at them at all times. Some people with atrial fibrillation is very common as we get older to have it all the time through our life. So it's just managing these things. Pericardial disease, we had talked about that little sac around the heart that is the tissue that kind of protects it, lubricates the area. Well, if that gets inflamed, you can get an infection there, things like that. Sometimes it gets fluid filled in there. And well, the heart is a sensitive guy. He goes, when he contracts, he shrinks down. If fluid's up on top of him, well, now when he tries to fill back up, he can't. And so that happens over and over. And so pericarditis, that's that disease. That's what happens. There's a fluid. And so we have to drain that fluid out. And that's pericardial disease, typically caused by viral viruses. Last but not least, congenital heart disease, similar to the cardiomyopathies. These are just people who are born with abnormal hearts. These abnormalities can be from very tiny, very small, to very large. Like they're relatively minor. And in fact, many of your generation have more heart irregular abnormalities because we didn't screen like we do now. Every baby who's born in our hospitals receives a cardiac evaluation before they're discharged from the hospital. And it's for these exact reasons, because we've seen that if we're able to intervene early, we can prevent delay of growth, we can fix a lot of stuff, or even, of course, the scary stuff like the hypoplastic left heart syndrome, where you just, you have the life-threatening event. The heart just doesn't work anymore. These are kind of showing that electrical signal that we typically see all on the movies that they always get wrong when, you know, the heartbeat that we see in all the movies and the TV shows. I guess it's more when they're doing the compressions, we see the flat line and how that works. Not always the same. But here, the atrial fibrillation definitely is shown kind of that spasm there up at the top. So last thing that we had kind of talked about, this is that action potential where the different electrolytes in our cells are having transport of sodium, potassium, chloride. They're going through, and if we can figure out where the error is and what's wrong, that we can prescribe medications directly for what we believe is going wrong. And this is where the cardiologists are choosing a lot of the different medications that you see with people with cardiovascular disease and heart disease. This is where we see the intervention of how this is affecting the beat of the heart through the electrical activity, through the electrolytes. So lots of different causes of heart disease, lots of different ways to look them up, to test for them that you can see in the office. Lots of ways that we can kind of interact and intervene with somebody with a heart that is not performing healthily, and we have abilities to do that. But the thing that's the most important out of all of this is that exercise and diet is going to be essential and paramount to promoting and keeping good health, healthy hearts. Again, lots of stuff is very variable. It is all depending on what is going on. So lots of questions that people had based on different medications and things. I leave those into the hands of the cardiologists or others, unless they're kind of the basic treatments that we're kind of doing in the office. Again, hearts are very important, right? Information, medication, intervention, they've come a long way. The worldwide killer is heart disease. So we are trying to eliminate that by modifying, seeing risk factors, evaluating people, and getting them to get out and start that exercise program today to reach that 150 minutes of moderate to intense exercise, using that nutrition and diet as to go along with it. Someone asked, what's more important, nutrition or diet? It doesn't, they are like breathing in and out. You can only do one for so long without doing the other. They go hand in hand. You have to do them both. Making sure we're eating lots of fruits and vegetables and limiting our risk factors, the smoking, a sedentary lifestyle, and eating healthy foods. So those are a lot of things that can promote a happy, healthy heart. I hope that wasn't too much. Thanks for bearing with me.
Thank you so much, Dr. McKenna. Let's see, can you hear me?
I can hear you.
Oh, okay. I'm not showing up. I'm not sure why, but that's fine. We did have, that was a tremendous presentation, a ton of information. I don't have the best memory, so if I ask a question that somebody has submitted and you've already covered it, please just let me know, or you can just kind of say that, but I'll just go through the questions that people asked. And actually, can you see the Q&A as well? Because some of these I'm not going to be able to pronounce correctly. But the first question is, I had pericarditis of unknown origin several years ago. Can you talk on this a bit?
So yeah, that was kind of actually just briefly, that was one of the last things I talked about.
That was the last
pericarditis. It's probably the unknown origin was one of those different viruses that are known to kind of cause the pericardial effusion. I actually think I have the ones listed because the most common ones were like, Mike, what did I have? But they were kind of really kind of irregular, not common viruses that we see on the everyday.
Right, that was the one with the fluid, right? Around
Correct.
and probably
the fluid around the heart, and it just sporadically happens. And as the heart pumps to beat away, then the fluid kind of creeps in over and over and over. And so then it can become quite an emergency very fast. And
you said it's sometimes caused by a virus, I think?
Correct. So the glandular fever, cytomegalovirus, and Coxsackie virus. Those are the ones most common to know, to just kind of do those sporadic pericarditis. But the way that you got to get that fixed is you got to get a needle right in there and they draw out that fluid. It's a scary moment.
But then once they do that, it won't necessarily come back, correct?
Not typically. Sometimes when the infection is recent and you've already kind of started feeling that, making the fluid to kind of protect yourself, it can kind of occur for that quick moment, but it is very, I would see irregular to see it as a recurring thing.
Okay, fantastic. Is an MI different than cardiac arrest?
No, essentially the one is the layman's term. We know he had a cardiac arrest, and an MI is short for a myocardial infarction. So that's what I was talking about, your myocardium, the tissue of the heart. In infarcts, that's where the tissue dies. So that's essentially the same thing.
Ah, okay.
Or they perceive the same thing. Sometimes when you're having an issue with the heart, people just say a cardiac arrest, but it could be a whole slew of things that are going on, right?
True. Does any part of our bodies get better as we get older? Oh, that's a hard one.
I think it's just the bank account where you're.
Yeah. Unfortunately. Why increase toe, calf, leg cramps? What should she do? Why are they increasing?
Well, usually the first thing I think of when I think of anybody having cramps is dehydration. And I was kind of talking about earlier, I don't know why, but as we get older, we know why. We just don't maintain that water balance as well. The hormones are different. We don't, the concentration of the urine. So typically we get those cramps in our legs like that, and that's where we notice it. So I typically try to increase a little bit of the water amount and see if that is able to kind of do any type of make a change. If that doesn't do anything, then you kind of go down another pathway of medical stuff.
Right. That's good advice though. What is pulmonary hypertension and is it dangerous?
Yes, so pulmonary hypertension is where it involves that right side of our heart, where we are now getting all of that blood flow returning back that now needs to go back into the lungs, and our body is going to pump that blood into the lungs, the pulmonary system. Pulmonary hypertension is that pressure we can measure, and if it is too high, that means that essentially at all times you have a high pressure hose pushing your blood as hard as you can into your lungs. And over time, that will cause damage to the lungs and the alveoli and the exchange there. So that's what pulmonary hypertension is. It's high blood pressure coming out of the right ventricle into the lungs. Is it dangerous? It can cause problems later on because you can have a buildup of fluid into the right side of the heart, and so the heart will start to dilate and those types of things. Another fun thing that I always like to bring up about pulmonary hypertension is that the medication, Viagra, was created for pulmonary hypertension. It was for blood pressure for this exact moment. But when it finally got to people to test a lot of the blood pressures, the side effect was they had an erection. And so that is how the medication came about. So we should thank pulmonary hypertension. Is it dangerous? It can be. So if we know you have pulmonary hypertension, that typically means you've gotten an echocardiogram, which is the ultrasound of the heart. And so then we just kind of keep measuring that and monitoring it.
Okay. Somebody used an ASCVD calculator, and it gave them the message, lifetime risk calculator only provides lifetime risk estimates for individuals 20 to 59 years of age. Is that correct? I thought it was 40 to 75, if I'm not mistaken. And that's typically because below 40, there wasn't any evidence that the calculation with your cholesterol and smoking and your sex and all that didn't really matter for your predictability over the 10 years. But after 40 to about 75, it was indicated. So I don't know if it was just had the time frame wrong there, but it's typically 40 to 75. And after that, I think it just becomes a discussion with your doctor, because we're just taking a gamble, over these next 10 years, what is the chance that you're going to have a heart attack? Well, if it's 25%, you probably want to take some medicine. If it's like a 1%, you probably don't need to take anything. So that's kind of where we kind of talk about it. Okay. What causes an aortic embolism?
So a couple things possible could be causing with an aortic embolism. So an embolism is where you've kind of got a clot that has gotten stuck and the aorta is going up. So a couple things happen with the aorta, you can have like a vegetation there where the valve doesn't, it's not working appropriately. And so the blood pools there right next to that. And so a clot is formed by the aorta. And then because this is the left side of the heart, it's scary because that blood gets pumped up to the brain and that can cause a stroke.
Okay.
So that can cause one of those other embolisms that we think of the heart. Atrial fibrillation is a really common cause of embolism, and that's because the heart is spasming, and instead of the blood moving in a smooth pool, it's now collecting. It's now starts to form those little clots, and once it gets in and gets pumped to someplace else, that clot gets lodged somewhere, thereby causing a stroke or an ischemia of something.
Okay. Drinking water equal to half of our weight in kilogram and ounces seems like very little water. A 150-pound person would only be drinking 34 ounces per day. Half our weight in kilograms and ounces. I see.
So I do remember it is, kilograms of your weight, and what half of that is how much fluids you should have, and then half of that should be clear fluid water, and then the other half could be milk, orange juice, tea, other things. I think that was a rule of thumb.
Okay. If it seems low, definitely drink more.
Correct.
My son-in-law's, sorry, there's some mistyping and I don't know what it is.
So I think it's my son-in-law's first thought he had a heart issue was pain or suddenly losing vision in one eye, and what could cause that. So, so sometimes if you lose the vision in the eye, again, we're thinking of an ischemic moment. So some sort of embolism, some sort of clot has broken off and has lodged its way somewhere. And sometimes it happens in the eye. Many people who have issues with their carotid, which is the vessel that's coming off of the aorta up to pump the blood to the head, can get really thin, and that can kind of break off little pieces, and that can cause people to get it into their eye and lose vision. Or again, the atrial fib, where the heart is spasming there, and then it forms a clot, and then once the heart pumps it away, it again lodges into the eye. Wow. So why the pain? I don't know.
Okay. Last question, can blood pressure be too low? If so, what's the impact and what level is considered low?
Yes, so blood pressure can be too low. So it's a kind of a rock and a hard place when it comes to blood pressure, of course. If our blood pressure is too low, those types of things like standing up and being able to combat gravity, we just don't have enough blood in our system, and we get faint, we pass out, we fall, and we hurt ourselves. Other things is when the blood pressure is so low, we are not having enough blood pressure to give our organs enough blood. They always need blood, right? We're worried about the hypertension, right? The pulmonary hypertension and other things. But if we don't have enough blood, or we have such a low pulse, they are not getting the blood. So they're almost as like they're going through an ischemic event too, because they're just not getting enough good blood. Typically the systolic, I believe, worrisome is below 70 over 30. I think if you're in the 30s, you're not able to adequately perfuse your internal organs. And so that is very worrisome.
Okay.
Again, we're aiming for the 120 over 80.
Yes.
And there is some wiggle room there. But the diastolic pressure, the second number for a family medicine doc, definitely super important for us for long-term consequences, because that's essentially what the pressure is always at and never goes below. So if that second number is very high, that means you're just always high pressure, injecting blood into all of your organs throughout your body. And 5 to 10 years of that, we do know that causes organ failure.
Okay. Well, fantastic. This was an amazing presentation with so much information. We will be sending out a follow-up with information attached to the email, and we will also be putting a recording of the longevity webinar on the Levy Senior Center Foundation's YouTube channel. So we'll be doing both of those by the end of this week or early next week. I would like to thank you, Dr. McKenna, for a fantastic presentation, and Ascension Health as well, and the Levy Senior Center Foundation for sponsoring it. So thank you so much.
Thank you.
And we'll let everybody know when we have our next Levy longevity scheduled. Thank you.